Hi, everyone. Good afternoon, and welcome to this special Fireside Chat in recognition of Lung Cancer Awareness Month. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota. Our team's mission is to reduce the burden of cancer by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, the importance of screening and early detection, treatment options, survivorship, as well as clinical research opportunities. My name is Amna Hussein. I am the Community Outreach and Engagement Manager on our team, and I will be moderating our Fireside Chat today. Every November is dedicated to raising awareness about lung cancer, its risk factors, and the importance of early detection. It's a time for us to come together, share knowledge, and work towards reducing the impact of this disease. Today, we are thrilled to have Dr. Naomi Fujioka as our special guest. Dr. Fujioka is a medical oncologist specializing in thoracic and head and neck malignancies. Her research interests include lung cancer and developing food-based chemoprevention against tobacco and environmental carcinogens. Dr. Fujioka is a principal investigator for cancer therapy clinical trials. In addition, she is an assistant professor of medicine in the Division of Hematology, Oncology, and Transplantation at the University of Minnesota Medical School. Dr. Fujioka is also a dedicated researcher at the Masonic Cancer Center, contributing her experts to carcinogenesis and chemoprevention research program. Dr. Fujioka's contributions to the field have garnered her numerous awards and recognitions. She was honored by the Minneapolis-St. Paul magazine, which designated her as a top doctor rising star. Her accomplishments extended to the cover of Minnesota Monthly Magazine's August 2021 issue. Dr. Fujioka is an esteemed figure in the field of oncology, and we are so honored to have her join us for this special Fireside Chat. So before we get started, I want to just cover a few housekeeping items. We will be recording today's session, so you can refer back to the recordings, and it will be posted on the Masonic Cancer Center's YouTube page. Please share it widely with folks who you think may benefit from today's session or are just interested in learning more. I would also like our audience to get familiar with using the Q&A feature, which is located on the bottom bar of your Zoom window. Throughout today's program, we encourage you to actively engage, ask questions, share your thoughts, reactions, and comments using the Q&A feature. We will have plenty of time following Dr. Fujioka's presentation for Q&A. For University of Minnesota employees and spouses participating in the University of Minnesota's Employee Wellbeing Program, I'm going to put a link shortly in the chat to complete the survey to mark your attendance today. All right, without further ado, I will now pass it over to Dr. Naomi Fujioka. Dr. Fujioka, the virtual floor is all yours.
Thank you so much. All right, I'm going to share my screen right here. Okay. All right, let me know if the slides aren't coming through, but so thank you so much for that kind introduction. Very generous, far more than I deserve, I think. And I appreciate everyone being here today. And I appreciate the opportunity to talk about a disease and a topic that is very near and dear to my heart that I'm very passionate about. So in the interest of time, from the perspective of me wanting to allow as much time as possible to answer questions, it may seem that I'm going to kind of go through these slides relatively quickly, but it has to do with the breadth of topics that I'd like to cover, and I'm very happy to answer any questions after today's presentation or at any time in the future. So can share my email address, for example. Always happy to talk about it. All right, so here we go. There we go. All right, so we're going to talk a little bit about a background of lung cancer, some about risk factors and screening, just a little bit on updates and treatment. And I say just a little bit because it's very difficult to cover all of the different things that are happening nowadays, but I'll cover some broad categories because it is very, very exciting and changing extremely rapidly. And then I'll talk a little bit about the chemoprevention work that I and others do here at the University of Minnesota. And then we'll circle back and leave lots of time for discussion and questions. All right. So I think it's useful sometimes, and given the breadth of the audience, to remember how cancer forms. And it really has to do with genetics of cells. DNA, RNA, and protein, that process that is very basic to our existence. And so here's just a little bit of an outline about that process. But really, cancer, the basis of cancer is really mutations that form in these genes. And this is just a pictorial version of how that might happen. So kind of keeping in mind this central issue of genetic damage from whatever it might have come from. And so in terms of why those things might happen, we have known factors, things like, and this doesn't apply just to lung cancer, but to all cancers. So some of the known factors are here listed. But the reality is, unfortunately, that there's many times we really don't know why a cancer happens. And even if somebody's been exposed to some of these known risk factors, not everybody, obviously, who is exposed to those risk factors develops cancer. And so we need to do a lot better understanding how this process works and identifying those at highest risk. And I'll talk about that in specific relationship to tobacco and lung cancer formation. So specifically for lung cancer, we know of a number of risk factors, and by far, tobacco use is the most common or highest risk factor for the development of lung cancer. That's still the case today. About 80% or so of cases are related to smoking, either people who are still smoking or people who used to smoke in the past but have already quit. But again, it's not just the smoking history that's important. We have to understand better which smokers and which former smokers are at the highest risk, because the reality is that approximately 20% of males, for example, who have smoked heavily in their lifetime will develop lung cancer from smoking. So that means 80% don't. And how do we differentiate between the two groups? Secondhand smoke is actually a very well described and studied risk factor, accounting for about 6,000 to 7,000, or about 3% of lung cancer related deaths in this country. And here in Minnesota, it's important to realize that radon is a reason for a number of people who die from lung cancer every year, approximately 20,000 in this country. And you can actually look at maps and show which areas of the country are highest in radon. And unfortunately, southern part of Minnesota is quite high. So we encourage, part of our education and awareness campaigns involve screening households for radon, which can be done very inexpensively nowadays and easily. A lot of people come to me in clinic and say, you know, somebody in my family had lung cancer. Does that have anything to do with it? And while there are some families who have genetic relationships to lung cancer, it's actually quite uncommon. So family history is actually quite rare. So getting to tobacco smoking, fortunately, the number of adults who smoke in this country is decreasing. And the figure on the left shows the prevalence or percentage of adults 18 years or older who do smoke. And the Black states are the highest rates, so about 19 to 24%. Minnesota's kind of in the middle. And then on the right side, you see the lung cancer death rates decreasing in both men and women, corresponding to the decrease in tobacco use prevalence in this country. But it's important to remember that tobacco use is not decreasing worldwide. So for example, it's still increasing quite dramatically in India. And so lung cancer is still a very serious problem, both in the United States and worldwide. I'm also going to spend a little bit of time talking about less well-known or less well-studied risk factors that plays into some of what I and my mentors are doing. But it turns out that environmental pollution and occupational exposures are risk factors for the development of lung cancer. We just don't have the knowledge and information just yet about how much or how these things work, but we have the tools to be able to get there. But things like benzene, things like acrolein, which I'm actually going to talk more about, polycyclic aromatic hydrocarbons, which are chemicals that result from combustion, so exhaust from cars, for example, burning, things that burn. Indoor coal cooking is actually a well-described risk factor, not so much in this country anymore, but in China, for example, it's clear that women who use coal fires to cook indoors are at higher risk for lung cancer. There's other things like arsenic, which we're exposed to in drinking water. primarily, and things like silica and outdoor air pollution. Asbestos in and of itself is little, a known risk factor for lung cancer, but in combination with smoking really enhances the risk of lung cancer, as well as another disease called mesothelioma. We also know that actually from work done in part here at the University of Minnesota, as well as primarily from the University of Hawaii, we know that race and ethnicity also seem to play a role. And this is work that looked at lung cancer incidence in 5 different populations, 5 different races. And the risk, and these were all in people who smoked, and the risk of lung cancer in smokers was highest amongst African Americans, as well as Native Hawaiians, and lowest in, for example, Japanese Americans. And that was even after accounting for how much people smoke per day or how much nicotine they were exposed to. And it has to do with likely how we process nicotine and cancer causing chemicals in tobacco smoke. So increasing information about how race might impact lung cancer development. I wanted to highlight this because loneliness is becoming a increasingly studied topic. And I was really shocked to hear, those of you who might have been at the Cancer Center symposium last Monday, a week ago, there's a researcher from Ohio who showed that mice who had a certain type of cancer actually live longer if they live with other mice, and the poor mouse who lived alone did worse. So the idea is that loneliness and social isolation also plays a role in the morbidity and mortality from cancers, including lung cancer. So switching gears just a little bit, we talked quite a bit about tobacco, and but I want to point out that lung cancer in never smokers is really a very under-recognized and yet stigmatized disease that we have to work hard to increase recognition of and develop new treatments for. And it turns out that 20% or so of women with lung cancer have never smoked, and that applies to this country. You know, that proportion can be as high as 50 to 60% of women in other countries, for example, like I mentioned, China. These women who have never smoked and developing lung cancer. And that's in contrast to 1 out of 12 men who have never smoked who develop lung cancer. And while we have many researchers are working on this, we really need to support the work that's being done to figure out why these cancers happen. All right. And also work together to increase recognition of the disease. And yes, it can happen. If you have lungs, you can get lung cancer regardless of anything else. And that really plays into diagnosis, for example, being delayed in women who have never smoked, and physicians saying, well, your cough is probably not lung cancer. How could you have lung cancer because you've never smoked? So I want to put a pitch out there to keep this disease in mind. If we look at it as a disease in isolation, separate from lung cancers as a whole, it would be the 8th leading cause of cancer-related deaths in this country. Okay. So the next part of the talk is focusing a little bit on prevention. So of course, we can do things to help ourselves to try to prevent cancer. And this is just a little schematic of some of the basic things that most of us have heard of something about. But even I admit that sometimes the recommendations are a little bit vague and generic, but things like maintaining a healthy weight throughout life, avoiding tobacco and alcohol, and eating a healthy diet. And then of trying to do your best to avoid some of the things that we know can lead to cancer, like tobacco and viruses, for example, and getting vaccinated and age-appropriate screening. So just a little bit of a description of when cancers can be prevented. So we can prevent them from happening in the first place. We can prevent them from causing more problems than they would have had we not intervened. And then we can actually prevent new cancers in somebody who's already had a cancer. So those are termed primary prevention, secondary prevention, and tertiary prevention. And just gives a little bit of an idea of where in the process are we trying to intervene so that we can prevent cancer. So the first part of that is, and probably most relevant and important to talk about for lung cancer, is screening. So we all know about colonoscopies and for colon cancer prevention or detection. We all know about mammograms to detect breast cancer and pap smears to detect cervical cancer. So lung cancer screening is also a real and very important tool to try to reduce the mortality and morbidity from lung cancer. So there are two guidelines, but they're quite similar. One is from the United States Prevention Task Force and the other is from the American Cancer Society. And I'll put a little plug in because this Saturday is National Lung Cancer Screening Day. But in the table, you see the age range that is included in the screening guidelines and the type of smoking history. So 20 pack years means somebody who smoked a pack a day for 20 years or, you know, whatever proportion to get to that 20 pack year history or more. And then the United States Preventive Task Force also includes current smokers and talks about how if you've quit smoking, we would screen up to within 15 years of quitting. But the American Cancer Society recognizes that the risk of lung cancer, while it decreases over time after quitting smoking, it never gets back to quite zero. So even after about 10 years after quitting or 15 years or so, people still have about 3 or 4 times the risk of developing lung cancer compared to somebody who's never smoked. And I just put some links into this slide on websites that talk about the lung cancer screening guidelines. Okay. The unfortunate reality is that we are all doing quite terrible in terms of lung cancer screening. So Minnesota is actually considered pretty decent in terms of the percentage of potentially eligible people who are actually getting screening, and it's only 8%. The average is 6%. So it's pretty bad. Because, you know, the reality is that in the big study in this country that showed that this is beneficial, the risk of death from lung cancer was reduced 20%, which is actually far better than the risk reduction, for example, with mammograms. But there's a lot of reasons for why this screening has not been more widely adopted. I would say that we're going to see some changes in the coming years. But we all really need to work hard to increase screening rates and help people understand the importance. Okay, I think in part it has obviously to do with some of the socioeconomic status issues that we know affect access to care. But I think in particular with lung cancer, there's a stigma that we also have to work hard to reduce. So people think that anybody with lung cancer sort of quote unquote maybe deserved it, or you know they did it to themselves, sort of thing. And that's absolutely not true. We know that there's lots of people out there who started smoking in the 50s and 60s before we even knew it was bad for people, and can't quit because nicotine is so addictive, and we don't have the best tools to try to help them quit. I mean, they so desperately want to quit, but they can't. So there's people like that to think about as well. And we all have to work hard to reduce that stigma. And I think by doing so, in part, we can increase screening. Okay. So the stark reality is that lung cancer still is the #1 cause of cancer-related deaths in the United States, and in both men and women. It's not the most common cancer in women, you know, but breast cancer is far more common, but it's still the leading cause of cancer-related deaths. And I only put the figures here for women. Sorry about that. But next slide, it will show about 240,000 cases in the United States this year alone, and about 127,000 deaths. That rate is decreasing, but not by much. Worldwide, still the major cause of cancer-related deaths in most countries worldwide, 2.2 million cases and 1.8 million deaths. So staggering numbers of people are dying from lung cancer. Broadly speaking, there are 2 types of lung cancer. Many of you probably already know this, but there's small cell lung cancer, which is about 15, maybe 10 to 15% of lung cancers. Much more so than the other type, non-small cell lung cancer, about 80% of lung cancers, but small cell lung cancers are much more so related to smoking compared to non-small cell lung cancers. Within the non-small cell lung cancer group, there are a variety of subtypes, with the most common being something called adenocarcinoma. That's about 80% of non-small cell lung cancers in this country. Squamous cell cancers, or cancers that happen more in the airways, in those cells, is about 15%. And then less commonly is things like large cell carcinoma, large cell neuroendocrine carcinoma, and a few others. It's important to be aware of the symptoms that might suggest that somebody should get checked out and might have lung cancer. Cough is very, very common. Sometimes people have pain somewhere or other. Most of the time people say, you know, in hindsight, I realized I was more tired than usual, or my appetites just seemed off. There's other more dramatic things like coughing up blood, or having a bad headache, let's say, if cancer is already spread to the brain, or some hoarseness if one of the nerves that runs along the side of the middle of the chest is affected by a cancer. I think getting back to the people who have never smoked who have lung cancer, one of the most common things we see is that they develop a cough and don't feel the best, and they go to their primary care doc and say, okay, you have a little fuzzy on your little shade on your x-ray, so let's treat you for the pneumonia. You know, let me know if it doesn't get better. A month later, it's not better. They say, okay, let's try a different antibiotic. Doesn't get better. A month later, they come back and say, okay, something's up here, so let's get a CT of your chest, and lo and behold, there's something more than pneumonia. So that's actually one of the most common things that I see as a clinician in how lung cancers are diagnosed. In terms of evaluation, it's pretty straightforward. We get CTs, we get PET CTs, especially in the beginning. In more advanced cancers, anything other than the very earliest stages of the lung cancer, we'll get a brain MRI to take a good look at the brain. We need obviously a biopsy to prove that it's lung cancer. And then if it's early enough stage, before we're thinking about a patient having surgery for lung cancer to try to cure it, we want to make sure that we look at those lymph nodes in the middle of the chest, which is the first place that a lung cancer is going to spread to when it decides to leave where it started in the lung. And that's how we accurately stage and thoroughly stage lung cancers nowadays. I bring this up because a lot of community practices, not so much in the Twin Cities, but places that may not have the resources to do this or whatnot, they often skip this step. So we have data that shows that PET scans can miss cancer in the lymph nodes. We also do blood work, and then on the biopsy material nowadays, for almost universally, for almost everybody, regardless of stage, we look at something called PD-L1, which is a characteristic on the cancer cells. And then we look at the molecular and genetic characteristics of these cells, of these cancers. And the reason why that's important is because if you look at the pie chart on the right side, you can see that actually the majority of people with lung cancer, these cancers will have some kind of genetic or molecular characteristic that we can take advantage of. So all the italicized letters are names of genes, and the proportion of patients whose cancers have these genetic alterations. And you can see actually on the right side of the pie figure, it's only about a quarter or so of patients whose cancers don't have something. And while it might not play a role immediately, it's always, we have to know about this. The reason why I spend a little bit more time talking about this is that the uptake of thorough genetic and molecular analysis on non-small cell lung cancers, we don't actually sequence small cells quite yet. I think we will in the near future. But the reason why I bring this up and spend a little bit of time on this is because the reality is that this is still not being done, even though it's considered very standard of care, and it has been so for many years now. Is still not universally adopted. And there's all kinds of reasons for that. But is critically important because it makes a huge difference, or it can. So I'm not going to spend too much time on talking about treatment in the sense that there's many, many things going on. It's not possible to talk about in a short amount of time. But just to give a brief outline of how we decide how to treat non-small cell lung cancers. Okay, so I'm going to concentrate on non-small cell lung cancer as opposed to the small cell. But first of all, we look at characteristics like PD-L1. We look at, of course, stage, you know, how advanced or how early it is. And in the advanced stage, where we cannot cure the cancer, this is an example of an algorithm that we use in terms of determining how to treat the cancer using standard of care approaches. So we look at PD-L1 and we look at whether it's a squamous cell carcinoma or a non-squamous cell carcinoma. And we have, the good news is that we have options nowadays. We have several options that we can choose from. So that's the primary point of this slide. And again, speaking to the importance of molecular and genetic characterization of these cancers, this slide outlines some of these characteristics for which we have drugs to target them. And then I added some newer ones there at the bottom that are not yet FDA approved or are coming up in terms of likely to be FDA approved. Okay. This slide is just an example of how survival rates in incurable metastatic or locally advanced lung cancers has changed over the last 10 years. So it turns out that when I started my career as a faculty member in 2011, roughly about the median overall survivor for somebody with metastatic lung cancer was somewhere on the order of about 10 months. And the range was not that wide. So most people died within a year. About 6 years ago or 7 years ago or so now, maybe even 8, people started developing the first round of immunotherapies or medications that try to allow the immune system to treat cancer. And this is just one of many examples of a clinical trial that led to the approval of a medicine called pembrolizumab, which is a PD-1 inhibitor. So tries to take the cancer cell's ability to hide from the immune system away. And it compared people whose cancers had PD-L1 proportions of more than 1%. So what does that mean? It means that if you look at 100 cancer cells under a microscope and see how many of them had PD-L1, we look at what percentage out of 100. So anybody whose non-small cell lung cancer had a PD-L1 expression of greater or equal to 1% and got pembrolizumab alone, so no chemotherapy, they compared that to people who got chemotherapy, which was the standard of care at the time. And people who got pembrolizumab did better for the most part. And what I want to highlight is that while people who got chemotherapy in the study actually did better because there's things like crossover and other stuff that aren't related to the treatment, the proportion of people who are alive at for example, 3 years out, this figure was from 3 years out, and now we have 5-year and beyond data, is roughly about 35%. So, and in reality, you know, if you look at older data with chemotherapy alone, the proportion of people who would be alive at 5 years out from a diagnosis of metastatic cancer would, in reality, be almost zero. But, you know, when you look at papers, it's going to be somewhere in the ballpark of 5% or less. So it's a substantial improvement. And much less toxicity for many people, although they can be quite toxic for some. This is a important study that changed how we manage stage 3 lung cancer. So lung cancers that haven't quite spread to anywhere else outside of the lungs and the lymph nodes in the middle of the chest, but are too advanced to take out with surgery. And this study was a big deal because the reality is that most people with stage 3 cancers, their cancers would come back relatively soon after we finished treatment that, you know, did have a chance to cure the cancer. But by giving 1 year of immunotherapy after the initial portion of treatment, which consists of chemotherapy and radiation, we've helped people survive quite a bit longer. And so these are called Kaplan-Meier curves, and the blue line is the people who got this medicine called durvalumab, and the people in orange, the orange line represents people who got placebo. And you can see that people who got durvalumab survived longer. Data is much more nuanced than this. There's different subsets of people that we look at, but this is kind of the overall data of the study population. And the point is that people are doing better. So we have, you know, I was very excited to see this because, like I said, the vast majority of people that I saw in my clinic who had stage 3 lung cancers, their cancers came back within the first year after pretty intense treatment. This is just an example of one of many, many, many studies that give people who have earlier stage lung cancers chemotherapy and immunotherapy, or in some of the earlier studies, immunotherapy alone prior to surgery. And the people who got nivolumab, which is a immunotherapy, plus chemotherapy prior to surgery and then had surgery, did far better than people who got chemotherapy alone. And so this is actually a standard of care that we use at I and my colleagues use at the university, where people who who have early enough stage lung cancer that they're eligible for surgery, we might give them 3 doses of chemotherapy and immunotherapy prior to surgery. Okay. But that brings me to the next line in terms of treatment advances more recently, is what do we do for people who have early enough lung cancers that we can take them out and cure them with surgery, but we need to do better because the cure rates are still pretty low. And that's really where a lot of change is happening in the last 2 years and will continue for the next several years. And I just listed out several studies that are looking at this question and how do we best incorporate treatment before surgery and then after. Okay, so what I think is going to happen is that we're going to do both, and what we do after surgery is going to depend kind of how a cancer responds to the treatment before surgery. The real amazing thing about stuff like this and giving treatment before surgery is that in people who go to surgery, which is the vast majority of people in these clinical trials, when the doc looks at the cancer under the microscope, they can't find cancer in about 24% of people. And that's pretty consistent amongst various studies that use the same approach, which is pretty remarkable. And those are the people who actually tend to do better long-term. So stay tuned about how this landscape is going to change over the next several years. And the idea is that it will change. Okay. There's some other things that are coming up in the next several years that weren't paying attention to that I'm pretty excited about, and mostly has to do with novel immunotherapies. Again, different approaches to try to understand how to use the immune system to treat cancer. And there's things called T-cell engagers, and then using cells basically as a cancer treatment. So keep your eye out for developments there. There's things called antibody drug conjugates, where they attach a drug that kills cancer cells to an antibody that binds to cancer cells, and basically think of it as a drug delivery system in a way. And then we have to understand the immune system better about how it manages cancers, and then understand why some of the immunotherapies that we have now don't work. So lots and lots of work going on, but this is kind of a broad overview of some of the things that I'm excited about. Okay. So we're going to switch gears completely, and I'm running already a little bit short on time. So I'm going to just really rush through this a little bit to allow more time for questions. But I want to introduce this concept of chemoprevention because it's not familiar to most, but here's a broad overview of what that means. Okay. And has a long history, not things that we use in general practice nowadays for the most part, because a lot of these trials were unfortunately negative, meaning they didn't show a benefit, and actually some showed harm, for example, beta carotene. So it really reduced the enthusiasm and excitement for developing other chemopreventive agents for a while. But it's also very challenging because we don't know how to identify people who are at highest risk for developing certain kinds of cancer in general. And there's all kinds of other reasons why this is a difficult field. But nonetheless, we're very excited about it, and we do a lot of work here at the university. Okay. I'm going to skip this slide in the interest of time, but our group focuses primarily on how cancers start, and going back to that initial concept that I talked about, where something damages DNA. Okay, and that's really the first step that leads to cancer formation. And my mentor, Steve Hecht, and others at the university study a bunch of different carcinogens or cancer-causing chemicals in tobacco smoke. And you see a list here on the top, and some of the metabolites or chemicals that our bodies produce in response to these carcinogens in the orange there. And they've actually developed methods to measure them, quantify them, so we can actually better understand the level of exposure and how it affects an individual. And at the university, there's also been interest in how something called cruciferous vegetables, which are a certain family of vegetables, like cabbage and Brussels sprouts and broccoli, for example, can affect the way that an individual might process cancer-causing chemicals or carcinogens. And we use something called phenanthrene, which is shown on the left, as a tool to study that in part. Many other ways to do that too, but the idea is that it can reduce metabolic activation, which is a required step for the carcinogen to become carcinogenic. and increased detoxification. And how people do this is very individual and affected by a number of factors that are specific to that individual. So we don't all do this the same. And I want to just point out that there's the chemicals in these vegetables that make them interesting are called glucosinolates. Okay, and we study a variety of end products. For example, PEITC and indole 3-carbinol are two common ones that I've spent time on. And then we just, some data showing that, yes, we can affect the way that people process these chemicals by giving vegetables. This is a study that I did in 2014 or something like that. All right, so all preliminary data. Right now, probably the most exciting thing that I'm involved in is a study that my mentor, Steve Hecht, is doing with Dorothy Hatakami in the tobacco research programs, looking at watercress. And that came out of a clinical trial where they gave the glucosinolate byproduct called PEITC to people who smoked. And they were looking at a particular carcinogen called NNK and its metabolism and didn't see anything promising, but they looked at other stuff too and saw some exciting effects on actually volatile organic compounds, which are a different class of carcinogens that I showed in several slides before. So right now, we actually have a clinical trial going on of roughly about 350 people, people without cancer. These are either healthy smokers or non-smokers. And they can get watercress or placebo first, and then they take that for 2 weeks, and then they switch over to the other one, whichever one they didn't take first. And then we're measuring metabolites of acrolein, crotonaldehyde, benzene, and 1,3-butadiene. So stay tuned for those results probably sometime in next year or the year after. Okay, and this is just an outline of the trial. I've also spent some time working on kava, which I'm not going to talk about right now, but just some slides to refer to some of the work we've done in a similar vein, and to put increase awareness of a clinical trial that I'm starting probably in about 2 months or so, looking at the effects of kava on anxiety and stress in cancer survivors. So this would kind of fall into the category of this tertiary chemoprevention that we talked about, although in this particular trial, we're going to be looking at its effects on anxiety. So I know I haven't explained what kava is and whatnot, but just want to put it out there that we're going to do a trial like this. So lastly, I want to spend 2 minutes on speaking about acrolein. So I mentioned acrolein way in the beginning as something that might be a risk factor for developing lung cancers. We're exposed to it from various sources, for example, our diet, and we actually make some acrolein in and of ourselves. But primarily, people are exposed to acrolein through either tobacco smoke or pollution. Okay, and they can create DNA addicts and then lead to genetic damage that eventually leads to cancer. Okay, its effects are also, for example, it can inhibit the way that DNA repairs itself, and so there's a variety of ways it can lead to cancer. Potentially. We don't actually have the strongest proof that it actually directly causes cancer, but it's felt to be a likely carcinogen by the IARC. And what we did is we looked at people with lung cancer whose cancers had EGFR mutations or ALK rearrangements. So these are two genomic characteristics that are typically associated with lung cancer and never smokers. And we looked at the DNA addicts, which are, you can think of as a gauge of DNA damage. We looked at levels of DNA addicts in these patients related to acrolein, just from the cheek cells. Take a little brush and get some cells. And we saw levels that were intermediate between never smokers and current smokers. So because acrolein has a lot of different effects, we're going to try to study those effects in people with lung cancer who have never smoked. And so hopefully we'll have some results by next year as well. So where are we headed with all this? Well, ultimately, I want to be able, and my colleagues want to be able to recommend some dietary interventions that could contribute to the prevention of cancer caused by environmental and tobacco carcinogens. Of course, understand why it works and how it works. Something that we can do widely and easily and affordably. We really have to better understand how the immune system works much earlier in cancer formation. I didn't talk at all about this, but something that I've been thinking about. And then absolutely, we need to better identify those at highest risk for developing lung cancers from various carcinogens, not only from tobacco smoke, but from the environment. So some take-home points that I want to leave you with is that lung cancer remains the most common cause of cancer-related deaths. We have to be aware that lung cancer in never smokers is a real disease, and we need to increase awareness. We need to be better able to characterize people's exposures to carcinogens and their effects. We need to improve lung cancer screening rates and keep an eye out for new developments in treatments because they're coming along all the time, which increases hope for longer survival and better quality of life. And then we hope to prove how food-based chemoprevention strategies can mitigate lung cancers. So with that, I'll end, and I will actually stop sharing and leave the last 20 minutes or so for questions.
Thank you so much, Dr. Fujioka, for providing us with, oh, it looks like did I freeze?
No.
Can you hear me? Okay. Thought I froze for a second, but thank you for providing us with such an enlightening and an informative presentation. So now we're going to transition to the Q&A portion of our program today. So I invite everyone on the call today to submit your comments and questions. But before we do that, I'm just going to get our fire started because in true fireside chat fashion, it is not a fireside chat or a fireside chat discussion without getting our fire started. So give me one moment to get that up. All right, so while we wait for questions to trickle in, I have quite a few actually that were submitted before our session today. So during the call, I mean, you mentioned the risk of developing lung cancer in non-smokers. Is screening is advised even without any specific or known risk factors?
So unfortunately, no, the only lung cancer screening right now is for people who are either currently smoking or used to smoke. And that has to do with the idea that we don't know which people are at risk for developing lung cancers who have never smoked. So we have to work hard to try to figure that out.
Thank you. And then, so on that note, why is shared decision-making important specifically for lung cancer screening?
Yeah, that's a good question. So granted, I'm not in the research of lung cancer screening and whatnot, but the idea is that, you know, if you look at the lung cancer's National Lung Cancer Screening Trial, it was called NTLST, anyways, NLST. If you look at how many people have spots in their lungs, we call them nodules. They're actually extremely common. So the idea is that we're going to find nodules and we're going to cause stress and concern and additional scanning and this and that in not an insubstantial number of people. So especially here in Minnesota, many of us have nodules in our lungs. What I would say in defense of that is that we're getting much better at predicting which nodules look like trouble and which ones don't, and when to watch and when to intervene. So that also makes a big difference. You know, there's actually algorithms to predict the likelihood that a nodule that we find on a lung cancer screening test is going to be something nasty.
Thank you for that. And Dr. Fujioka, do you know of just resources or where folks can get more information about testing their homes for radon? What is out there in our state?
Yeah, so I put in a link. It's a little bit small on the slide that talks about radon as a risk factor for lung cancer, but the state has created access to programs that facilitate screening. Basically, they'll send you a little radon monitor and you send it back in and they tell you the measurements. I think the part that still needs development is, you know, what do you do if you find out your house has radon? Because radon mitigation systems are expensive. And the state is, what I know is that the state is working on programs to help with that. But that's going to be a major factor in, you know, reducing the morbidity from radon exposure.
Thank you for that. And it looks like there was a question that was just submitted. So you mentioned often your patients come to you after several months of working with their primary care provider to diagnose a cough, for example. From your perspective, are there ways primary care providers can potentially catch lung cancers sooner without ordering excessive scans?
Yeah, so I think the first step is awareness that lung cancer can happen in people who have never smoked, and that lung cancer can happen in former smokers. I think primary care providers are often more readily more readily order scans for people who are current smokers or maybe have recently quit. I think there's a lot of self-advocacy in this too, though, fortunately or unfortunately. And so I think it's a very tough question without easy answers, because the excessive scanning is also a big deal in terms of the financial impact on society, as well as the concern that it can cause sometimes unnecessarily for an individual. But that's where talking to your doc about it comes into play. And I think honestly, the first step is being aware that it's possible to have lung cancer even if you've never smoked.
A good point to just for folks to kind of keep in mind, just being aware of your body and any changes that you are observing. So as a medical oncologist, what are challenges that you have faced when making treatment decisions for patients diagnosed with lung cancer?
Yeah, so this is kind of true for any cancer. And, you know, I'll put a pitch out there for self-advocacy again, in the sense that what we do initially for cancers is pretty straightforward. I pointed out some of the little areas specifically for lung cancer that to be aware of. If you know somebody with lung cancer is just starting a journey into this, or have lung cancer yourself, or whatever it might be. But beyond the first type of treatment for a cancer, sometimes beyond the second type of treatment for a cancer, that's where we start looking into earlier phase data, experience, new data, and that's where insurance companies often lag, and we have to fight hard to get treatments for people, approved for people. I think the other part of it is to be proactive and think about clinical trials. So I'm not going to, you know, it's a long discussion about what clinical trials are and what that means, but to think about novel treatments that you might not otherwise be able to access, and being open to that possibility, because the stark reality is that beyond the second or third type of treatment for many cancers, maybe, you know, with the exception being breast cancer and several others, but certainly for lung cancer, the standard of care treatments are not that exciting. And we're talking about incurable cancers here. So being open to new treatments that might be available, including trials that we have here at the university. You know, we're lucky to be in a landscape of very active research. So other colleagues at Health Partners or Alina or whatnot might have clinical trials, and certainly our colleagues at Mayo Clinic have trials that we don't have, and vice versa. So we've really tried to open up the avenues there to help all of us improve access to these trials.
And I think I've heard actually clinical trials being referred to as tomorrow's cancer treatments today. And so thinking about it, it is the future of cancer care, and just a good plug for folks to just see what's available to you at the university and just kind of throughout the state and nationally. And so there's another question that was submitted specifically about treating metastasized lung cancer to the brain. So how is it typically treated? I know you kind of mentioned a little bit about it during your presentation, but typically how is lung cancer treated when it has metastasized to the brain or other parts of the body?
So specifically with the brain, it depends. Sometimes some of the medications can actually manage cancer that's already spread to the brain, specifically immunotherapies like pembrolizumab or nivolumab, some of its cousins, and the targeted therapies that take advantage of these genomic and molecular characteristics. It depends how big the spot in the brain is and whether it's causing symptoms or not. So there's a number of factors that go into decisions about whether you have to target the brain specifically or whether you can try medications first. If we're talking about targeting the brain specifically, we typically do that with radiation. And for non-small cell lung cancers, unless there's many spots, and the definition of many can change from institution to institution, but, you know, kind of pulling a general number, if there's more than 10, then generally speaking, the radiation doctors will want to treat the whole brain. Some places actually go up to 20, but there's not really good data for that. But if it's less than 10, they'll typically do a focused type of radiation. Here we call it gamma knife. Here at the university, we call it gamma knife. It just has to do with the system that they use here. But the concept is called stereotactic radiation. So very, very focused radiation that doesn't damage the tissue around the healthy tissue around a spotted cancer, and gives high doses of radiation to the spotted cancer.
Thank you for addressing that question. So keep the questions coming, submit questions that you have in the Q&A, please. And then we'll move on to another question. So you talked about dietary recommendations, but as a provider, how do you advise your patients on, specifically your lung cancer patients, on which dietary recommendations or guidelines they should be following?
Yeah, so that's a tough one for me too, because I'm particularly interested in nutrition and actually supplements, but we follow the broad guidelines that are recommended to everyone, which is a balanced diet and, you know, a certain number of servings of fruits and vegetables per day and this and that. But beyond that, it's hard to say anything because there aren't enough data to support what I think, which is, you know.
Tell us, what do you think?
You know, there's things like trying to avoid processed foods, which you know has no basis in data. I think to the level that we could actually make recommendations about that, and there's certainly all kinds of socioeconomic factors that we have to consider when we are thinking about those things, because access to healthy food is different amongst different populations and parts of the country, and et cetera, et cetera. But you know, if there's data showing that processed food is kind of bad for us. And I think, honestly, hoping that the research community supports more research and efforts to really dissect this topic much more carefully and much more thoroughly than we have resources to do so now. Because you know, diet is really such a huge part of our life. And I really do feel that it does make a difference somehow. I just don't know how. And I don't know what, but yeah, so, you know, we usually have people work with a dietitian actually. And then I think there's something to be said about being creative about the ways that you can get good nutrients and at low cost and that are widely available.
Great, thank you. So we have time for just a few more questions. So you talked about this, but this question came through. What are some of the misconceptions or the common misunderstandings that the general public often have about lung cancer, and how can we work to raise awareness and dispel these misconceptions?
Yeah, so the lung cancer and never smokers idea is a big one. The idea that people with lung cancer should be blamed because they brought it on themselves, you know, that kind of nonsense really needs to be mitigated. Guilt plays no role in this disease. It's so much more complicated than that. And, you know, really campaigning to bring awareness that this is an important disease. I mean, if you look at funding for lung cancer research compared to breast cancer research, you know, a lot of people say, oh my gosh, breast cancer research gets so much more funding than lung cancer research. I actually think it's the opposite, in a sense that, you know, the people who are passionate about breast cancer really advocated and campaigned to increase research funding for that disease. And the lung cancer community is trying hard, but we have to expand that and keep on pushing because it is, again, the most lethal cancer in this country amongst both men and women by far. So those are some of the common myths and misconceptions that we have to work on as a society. And that there's going to be increasing data over the coming decade about lung cancers that happen for other reasons. And again, it's not just smoking that leads to a person getting lung cancer. There's other factors involved in that. Otherwise, everybody who smoked would get lung cancer, and that's not the case.
I mean, as you said, if you have lungs, you can get lung cancer. So I think we need to really spread that messaging out there. So there was a question that was just submitted, and this will probably be our last question, but you touched on some of the environmental exposures that can contribute to lung cancer. Are you aware of research on exposure to other inhaled substances that have been getting more attention lately, such as microplastics and PFAS? Do you think the incidence of lung cancer may increase as these sorts of environmental exposures and just some of our the natural disasters that we see, like forest fires, become more common?
Yeah. So I actually don't know if I've come across questions about microplastics and PFAS specifically in relation to lung cancer. Probably just, I don't know. With the wildfire stuff, that's where that particulate matter and risk factor as a risk factor for lung cancer comes into play. We know there's a lot of particulate matter in wildfires, and there's increasing more epidemiologic data showing that people who live in high particulate matter areas, so related to pollution primarily, but also could be applied and studied specifically in wildfires, can be a risk factor, can be associated with a higher incidence of lung cancer in those epidemiologic studies. With the wildfires, actually, acrolein exposure, for example, as well as other chemicals come from combustion or fires. So, for example, we might study firefighters as a population who might be at higher risk for or have higher levels of certain carcinogen exposure. And I think some of that work can be applied to wildfires as well. So yes, I think that as wildfires become more common and global warming is a bigger issue, we may see data coming out in that regard.
Thank you so much. It looks like that was all of the questions that were submitted. So we are going to have to wrap it up here. Thank you everyone for the engaging questions and for tuning in today. And a special thank you to you, Dr. Fujioka, for sharing your expertise with us during this fireside chat. So as we conclude, let's remember that Lung Cancer Awareness Month is a time to increase awareness, knowledge, and take proactive steps towards lung cancer prevention. So after our session ends today, Zoom will populate a window to complete a brief survey for us. We would greatly appreciate if you could spend just a few minutes to provide us with your thoughts and feedback about today's fireside chat, as it helps us improve and tailor our content to your interests. After submitting the survey, don't close the window, because there will be a link for you to enter the drawing to win a prize pack filled with goodies from the Masonic Cancer Center. The survey link will also be sent in the follow-up email tomorrow. And everyone who tuned in today, excluding University of Minnesota affiliated staff, students, and faculty, will be entered into a drawing to win a $25 Target e-gift card. So keep an eye on your email, because 2 lucky attendees will receive that e-gift card. And mark your calendar for our next fireside chat on gynecologic cancers on December 15th from 1 to 2 p.m. And lastly, please make sure to follow the Masonic Cancer Center on all of our social media platforms to stay up to date on future announcements and upcoming events from the Office of Community Outreach and Engagement. Thanks again, everyone, for joining our lung cancer focused fireside chat with Dr. Naomi Fujioka. We look forward to your continued engagement in our future fireside chats. I hope you all have a wonderful rest of your day and week. Take care, everyone.